Hey everyone, my name is Alex Pond with the UNM Division of Community Behavioral Health. Welcome to today's webinar presentation for the Rural and Community Psychiatric Residency Program webinar series. A few announcements before we get started. Please make sure your sound is muted during the presentation. If you have any questions, please submit them in the chat or feel free to unmute if Dr. Abeyta opens up the floor. For those requesting a CE or Certificate of Completion, I'll share an evaluation link in the chat towards the end of the presentation. In order to receive a certificate, you must attend the full presentation. Also, please note that the link will only be active for 48 hours after the presentation in order to receive the certificate. If you have any questions about this, please feel free to reach out to me directly. And I will now hand it over to Dr. Abeyta. Thank you.
Awesome, thanks, Alex. So my name is Dr. Abeyta, and today I'm going to be presenting on serotonin syndrome and other psychiatric emergencies. And just a little bit about me. I'm a second year psych resident. I'm at the University of New Mexico Psych Program. I'm from Socorro, New Mexico, so I'm a New Mexico lifer. I came to undergrad here at UNM and then stayed for residency. My wife is also a family medicine resident. We have 2 kiddos. I'm happy to be giving this presentation. I hope it will be educational and everyone can learn a little something, learn something new every day, I think is what, a good advice for anyone. So here's the certificate, continuing education that Alex just went over. And if you have any questions, I think you can ask him. I don't have any financial disclosures related to this presentation. This disclaimer, the views expressed in this presentation are those of the speaker and do not necessarily represent the views, policies, and positions of the University of New Mexico. And to go over our learning objectives, so number 1, first, I wish that we hope to identify the risk factors of the selected psychiatric emergency syndromes, including serotonin syndrome, neuroleptic malignant syndrome, and malignant catatonia. Number 2, be able to interpret signs, symptoms, and lab studies to distinguish between the psychiatric emergencies. And number 3, be able to formulate a plan for immediate treatment to prevent severe adverse outcomes. In terms of cultural considerations, there wasn't much, except most of these are US-based references, and so mostly generalized to the US population. Okay, so we're going to get started here. And one thing before I start talking about what's on the slide is I like to kind of just talk about the name of the presentation, which is Psychiatric Emergencies, which is a little bit tongue-in-cheek, a little bit of a hyperbolic title. There are definitely psychiatric emergencies, many psychiatric emergencies, such as, suicidality, homicidality, psychosis, psychotic break, mania. What we're mainly going to be talking about today are emergencies that are brought on by psychiatric medication, and they're somewhat medical emergencies. And so it's kind of like a little bit of a clickbait title on my part, just to kind of bring awareness to these different syndromes. So first, we're going to talk about Libby Zion. And Libby Zion was a 29-year-old freshman in college. And her case is a pretty famous one, so I wouldn't be surprised if people have already heard about this, but I think it's a good start to introduce what we're going to be talking about. So she was going to a college in New York, and in 1984, she went to New York Hospital. She was on an antidepressant already, and that medication was called phenelzine, which is one of the MAO inhibitors. And she went to the hospital because she was having some stomach pain. When she went, it was pretty late at night, and she was already pretty agitated and anxious when she got there, and in quite a bit of pain. Taking care of her were 2 resident physicians. One was a second year, and one was an intern, and they were under the under an attending physician, and he was given all the data about the case as well. So they decided to give her an opiate medication called meperidine, and that was to mostly control for rigors, because she was like moving a lot. So they gave her that medication, and the intern went to the call room, and they had their pagers, and pretty soon they got a page that Libby actually wasn't getting better, and she was becoming more agitated. In fact, she was becoming so agitated that they had to put physical restraints on her. Her vital signs started to become pretty out of whack. Her temperature got up to 107 degrees. And, quickly the second year resident and the intern ordered stuff to try to stabilize her vital signs. Unfortunately, she had a cardiac arrest before her vital signs could be stabilized, and she ended up passing away that night. And there was, three pretty important outcomes, stemming from this case. And this is a pretty, well-known case. It's in multiple medical journals. The first being that it led to the resident work hours that is known today. So residents aren't allowed to work more than 24 hours in a shift, and there shouldn't be working more than 80 hours in a week. The two residents that were working on this case were coming off and they were working pretty much their 36th hour. So, this was, the case that brought on the realization, like, maybe that's not a good idea to have residents work that often, so many hours in a row. The second thing was the medication that she was taking, phenelzine, which is, like I said earlier, a MAO inhibitor. These medications, ended up getting pretty much shunted out of the market in terms of antidepressants. And that's because, further studies were done and they were shown to have a pretty significant risk of serotonin syndrome, which is what we're going to be talking about. And then the third thing that came on is, serotonin syndrome kind of got put into the forefront as kind of this, very dangerous outcome of patients that are taking serotonergic medications. And so people became more aware of this. And it led to, like I said, that MAO inhibitors being used less widely, but, other medications, such as the opiate medication they gave her, which actually interacts with serotonin, that kind of information was more studied. So now we kind of know, what medications are the, big causes of this syndrome. And we also know that there's other medications that you might not think can cause serotonin syndrome, but one that we're more aware of now. So serotonin syndrome, it's mostly caused by serotonin toxicity. And specifically what it means is there's overstimulation of the serotonin receptors in the central nervous system. So we're talking about 5-HTA2 and 5-HTA2, HTA1 and HTA2. And it's thought to be more of a spectrum of symptoms. So in clinic, you can actually see kind of mild serotonin syndrome with, a little bit of hyperreflexia, a little bit of hypertonicity. And it's something that can, start off pretty mildly. And then if a medication's increased, then it can kind of go down the spectrum into a more severe case. So it can be seen in all age groups, coming down from infants all the way to very elderly patients. The incidence is actually thought to be increasing now that we're starting to prescribe more and more serotonergic agents. With Prozac coming onto the scene and the rest of the SSRIs, we're starting to see this a little more and more. Although I will say, the absolute incidence would still, make this a pretty rare outcome, but it's something to be aware of. If patients are overdosing on antidepressants, it can be an outcome. And like I said earlier, the MAO inhibitors like phenelzine and like parnate, are notorious for causing this just kind of as monotherapy by themselves. So there's not a lab test for this. Like, you can't draw someone's blood and determine that they have serotonin syndrome. It's a clinical diagnosis, which means you have to look out for the sign and symptoms. For serotonin syndrome, there's actually a specific criteria that you can use to diagnose it, and it's called the Hunter criteria. And the main one is there has to be a presence of a serotonergic agent. And we'll go over what some of those can look like in a little bit. But so you have to have a serotonergic agent, and then you have to have one of these next things. So either spontaneous clonus, which is, the patient will show that they have clonus without any stimuli. Inducible clonus, like, doing I'm going to mimic that my wrist is a foot here, but kind of doing the shake and to flex to pronate the foot, and then giving more than 5 beats is inducible clonus, plus agitation. Ocular clonus, which is, clonus in the eyes, and when you see, you can look up YouTube videos of ocular flutter or ocular clonus, but basically the patient's pupils can't really stay straight, and they kind of jerk back and forth. It almost would look like nystagmus, but it's at rest and not during movement of the eyes, plus agitation. Hyperreflexia, and the hyperreflexia here is pretty significant. We're looking at maybe hyperreflexia leading into some clonus along with tremor. And then hypertonia plus temperatures over 38 degrees Celsius plus ocular clonus. So, you have to have the serotonergic agent and then one of those to be diagnosed with serotonin syndrome. And you can see by the criteria, there's not like a mark of severity there. It's just symptom based. So you could see that you could have, a patient that has those symptoms, but is, vitally stable, except for the temperature one. If they had spontaneous clonus plus the presence of the serotonergic agent and their vitals were 100% stable, that might be classified as like a mild serotonin syndrome. We pretty much went over some of the symptoms, but the one that we didn't on the left there, their pupils are also usually dilated, and there's usually some GI component because we know our serotonin agents, we have serotonin receptors in our gut, and that can mess up our GI system. So these patients will often have like diarrhea, nausea, vomiting, or some sign of GI distress. The rigidity, and we'll see a lot of these symptoms are shared between the this and NMS. So it's kind of hard to tease them apart, but that's something we'll go over later. You'll also notice if you look at these, someone with opiate withdrawal can also share a lot of these. So that's why it's important for that Hunter criteria, the presence of a serotonergic agent, seeing if there is something that could be the cause of a serotonin syndrome. Okay, so if a patient comes into the ED and there's some suspicion of serotonin syndrome, they'll do a basic lab workup, CBC, CMP, liver function tests, and there's not really a specific lab finding, like I said in the previous slide, that would point them to a serotonin syndrome diagnosis. Stuff they can see is elevated white count, that maybe just a acute phase reactant kind of reaction where they get a leukocytosis. Similar, they have an elevated CK, and that is also something that can be seen in multiple of these syndromes. The complications from serotonin syndrome, you can get rhabdomyolysis, renal failure, and acute respiratory distress syndrome, which the patient could go into respiratory failure. You saw in our case earlier that Libby went into cardiac arrest, which is also another complication that can happen with serotonin syndrome. So what they do, if a patient has suspected serotonin syndrome is, obviously the first step is to discontinue the serotonergic meds, because that's what we're feeling is causing the syndrome. Vital signs are really important to keep stabilized. So if they start to build up a temperature, giving them antipyretics to keep down the temperature. If they're starting to become tachycardic, giving them fluids and stuff to keep the vital signs stable, because of the autonomic response, that's something that can get into a pretty dangerous territory. Benzodiazepines are the mainstay of treatment for serotonin syndrome, and that's mostly to help with the vital sign normalization and to calm down the agitation caused by the oversensitivity of the serotonin receptors. There has been some cases of severe serotonin syndrome where they use a serotonin antagonist. In this case, it would be cyproheptadine. If you look at the studies that compare using benzos with cyproheptadine, there's not really a clear-cut answer of when to use each one. If there is like an overdose of an SSRI or a serotonergic agent, I think you could be convinced to try out cyproheptadine, but most of the times we're talking about supportive care along with a benzodiazepine. And, we'd be looking at, like an Ativan IV, 1 to 2 milligrams and keeping on top of the agitation and the vital signs. Severe serotonin syndrome usually will need ICU management, and that's because most of the times if it's in a severe case, they can't protect their airway, and they may need to be intubated and need ICU level care. Also, the ICU provides the best way to be able to monitor vital signs and give medications quickly through an IV. So ICU is usually what is needed for severe cases. The symptoms usually revolve pretty quickly, usually within a day after discontinuing the serotonergic agent. And this kind of speaks to, how quickly this comes up as well. And this is one of the key differences to, keep note of. So serotonin syndrome happens pretty quickly. Usually within 24, to 36 hours after changing or adding an agent is when you could see the symptoms start to come on. And so, vice versa, when it resolves, it also resolves pretty quickly. And that's something that's a difference between the ones that we'll talk about later. The prognosis is generally favorable if the patients are able to get to proper care and go to the ED. Let's see, it's a duplicate slide. So best management is prevention, having informed consent when starting our medications. Like I said, the MAO inhibitors are known to be, the worst causes of this medication or of this syndrome, but all of our medications theoretically can cause this. Even, an SSRI on itself could theoretically cause serotonin syndrome. So it's also good to, put it in there with our informed consent as like a rare side effect and to have the patients be aware of the symptoms, especially because there is a mild version of serotonin syndrome. It's something that we can ask our patients if we start them on, have you noticed you've been shaking, or do you feel like you've had any increase in your temperature? Are they coming up to the clinic and they're having a fever? And another reason to be able to do a quick physical exam if the patient's feeling very uncomfortable and their vital signs are suggesting that they're not doing so well. Another thing we can do is be aware of uncommon medications that can increase serotonin. So a lot of medications that we prescribe, like the SSRIs, the SNRIs, and the MAO inhibitors can increase serotonin. But there's some other ones that we have to keep an eye out for. So meth and cocaine, most stimulants can increase serotonin and can also contribute to serotonin syndrome. So stuff like Adderall can as well. MDMA and LSD can also increase serotonin. Like in the Libizion case, meperidine, an opiate. Fentanyl can also increase serotonin. Lithium has also been shown to increase the incidence of serotonin syndrome. So there's actually a really good chart on UpToDate that you all can refer to that has a list of kind of uncommon medications that can increase serotonin. If you're prescribing a medication, it might be good to do a check of, other uncommon medications, just to make sure that we're not using a lot of these in combination. So, as I'm describing, the treatment, this is not something that can be done, unfortunately, usually out of an office or even in a psychiatric emergency room. If there's any question of if a patient has serotonin syndrome, looking like they're going to need IV treatment, they likely need to go to the medical ED. And even if there's like a question, like you're not very sure, I think medical clearance, letting the ED know that, there's things that are suspicious of serotonin syndrome is probably a good idea. Medication history is, the most important thing. If there was a change in the serotonin syndrome, if, they just did meth for the first time yesterday, and now they're having all these autonomic vital sign instability symptoms. So a good history here is important to determine what may be going on. Okay, so that's serotonin syndrome. Next, we're going to talk about neuroleptic malignant syndrome. And you'll see that there's a lot of similarities between these two syndromes, and that can make it pretty hard to tease them apart sometimes. So this is, another very severe, life-threatening neurological emergency related to dopamine. The classic symptoms, there's a tetrad of symptoms: mental status change, muscular rigidity, and this is described, as like lead pipe rigidity. So this is pretty significant rigidity. Hyperthermia and autonomic instability. So, you can see there's a lot of similar symptoms with serotonin syndrome. This one's pretty life-threatening. The mortality is directly related to the autonomic instability and the further systemic complications that can come from that. In the 60s, if a patient showed up with NMS, the mortality rate was estimated to be somewhere in the 70%, like 76%. Now it's in between like 10%. It's around 10%. So it's still pretty significant a percentage that can, end up in mortality. So something that we need to be aware of for sure. Similar to serotonin syndrome, NMS can happen in all ages. The incidence, if you look at the studies, there's unfortunately a wide range. 0.02% to 3% among patients taking antipsychotics can have some symptoms of NMS. I'd probably wager that this is more towards the lower side, but it's something that we should still definitely be aware of. It's most often related to the older antipsychotics like Thorazine or Haldol. Although, prescribing the second generation antipsychotics is still, leaving you up to the risk of causing NMS. And it's something that, again, like serotonin syndrome, we should be, telling the patients about for them to be aware of these symptoms. Like serotonin syndrome, there are other drugs that can contribute that are not just antipsychotics. The most classic of these are the antiemetics. So Reglan and Compro, like prochlorperazine and promethazine. Phenergan can also increase the risk of neuroleptic malignant syndrome. So a patient, that is taking, a Haldol dex shot along with daily Haldol, and then starts to get nauseous and is prescribed, Phenergan or promethazine. That's a patient that you'd want to watch out for as someone that would be at high risk for developing neuroleptic malignant syndrome. So this one, we're not exactly sure why it happens. The leading theory right now are dopamine blockade, which is what our antipsychotics do in areas such as the hypothalamus. The hypothalamus is a center of the brain that, can control for temperature and could be a culprit of the autonomic instability. There's also a question of if there's a hereditary component, if there's overrepresentation of dopamine receptors in certain patients, although there's a lot more studies that need to be done to determine. So right now, it's just kind of one of those things that we're not sure of why it happens. Just to go back to the symptoms again, so there's a tetrad of symptoms, and usually the presentation, it actually follows this pathway. So first, there'll be mental status change, and then the patient will develop rigidity. And then, they'll start to see some vital sign change like hyperthermia, becoming feverish, and then they'll have the autonomic instability. So another way that, we can tell the difference is how it comes on. Unfortunately, unlike serotonin syndrome, there's not a validated criteria like the Hunter criteria. It's also a clinical diagnosis. If a patient comes to the ED, because it looks like so many other syndromes, they usually get brain imaging like an MRI and even maybe like a lumbar puncture to make sure that there's nothing else going on like meningitis or something else that can cause rigidity and mental status changes. So talking a little bit about treatment, again, very similar to serotonin syndrome. So stopping the agent, discontinuing the antipsychotic, supportive care, so maintaining stability of the vital signs, making sure that temperature is under control, tachycardia is under control. there is antidotes, similar to kind of how we talked about serotonin syndrome. So basically dopamine agonists like dantrolene and bromocriptine. Amantadine has been studied as a potential, thing to do. Again, these are stuff that are used on a case-by-case basis. And in someone that maybe overdosed on their antipsychotic, you may want to consider using something like dantrolene. However, in the ED, as they're kind of trying to figure out what's going on, the most common thing is again, benzodiazepines and supportive care. If they're for sure that, they can say that this is NMS, then one of those other agents may be used, but usually a benzodiazepine like Ativan IV is used here. Complications, again, are similar to serotonin syndrome. You can have electrolyte imbalance, you can have renal failure, can also cause clots like DVT, and it can cause like a DVT or a pulmonary embolism. It can also cause cardiac complications like a MI and seizures. Again, if you're suspecting this is a person that needs to go to the medical ED. This is not something that can be taken care of in an office or even a psychiatric emergency room. And these cases, again, usually need ICU level care because if the patient becomes so rigid, then they're unable to protect their airway and they may need to be intubated. So here's a key difference. So like we talked about with serotonin syndrome, coming up quickly, resolving quickly, NMS is kind of the opposite. It takes a few weeks to build up. So because of that, it also resolves quicker. It could take weeks to resolve. So this is something that kind of has an insidious onset. You could see slight mental status changes coming on with rigidity that kind of builds up and up until it's very significant and starts causing vital sign changes. If someone's developing progressive rigidity and also having mental status change, but their vital signs are fine, it's probably worth sending them to the ED just to make sure that nothing else is coming up like a severe case of NMS. And then I'm going to talk about two more things, and I'm really quickly just going to touch on malignant catatonia. So this one is also really similar to NMS. It has the mental status changes and the autonomic instability, but this one comes up, as a severity of catatonia. So you're going to have a lot more positive psychosis, like hallucinations or repetitive movements like echolalia and echopraxia. So this would be something that would still meet criteria for catatonia, but it can appear pretty similar to NMS. The good thing for us is, the treatment for catatonia is very similar to what we just talked about, benzodiazepines and supportive care. So again, if there's any question, that's usually a treatment route that you can use for any of these things. So I just wanted to touch on that one real quickly because that's something that is pretty hard to distinguish from NMS sometimes. The next one we're going to talk about is anticholinergic excess. So a lot of our medications work on antimuscarinic receptors and can cause anticholinergic symptoms. It's something that is coming more and more into the literature as something that could be, anticholinergic medications have been found to increase the risk of dementia, later in life. So, but this what we're talking about in particular is a, acute case of excess anticholinergic symptoms. So these are the signs and symptoms that, are taught in the textbook. So mad as a hatter, mental status changes, hot as a hare, hypothermia, blind as a bat, so blurry vision, dry as a bone, so dry mouth, dry eyes, bloated as a toad, so some GI distress, full as a flask, and red as a beet, so skin flushing. So severe cases can include seizures, coma, respiratory failures, and again, cardiac distress can lead to MIs. So our medications can cause anticholinergic excess, like antidepressants, antipsychotic. Benzos, can also been shown that they could cause anticholinergic excess, probably not as much as the first two. This one, a lot of other medications can cause anticholinergic side effects, such as antibiotics, like ampicillin, vancomycin, antihistamines, of course, like Benadryl. Hydroxyzine is something we commonly use. So someone that, takes too much of their hydroxyzine and starts to feel drowsy and blurry vision, they're starting to see that anticholinergic toxidrome, but just not in a severe case. Opiates like morphine and oxycodone, medications to help with GU stuff like oxybutynin and furosemide and HCTZ for cardiac, and like loperamide can also cause anticholinergic. So this is another one that, so many medications can contribute to like an excess anticholinergic. And it's also another syndrome that is very on a spectrum, that you can have mild anticholinergic symptoms like dry mouth and dry eyes, all the way up to, severe cases where it's causing, seizures and coma. So again, another plea to make sure that in our informed consent that we're, making sure that we're covering our bases and talking about these different toxidromes that can happen when stuff happens in excess. So treatment usually can either be, similar supportive care, benzos. Physostigmine is an anticholinergic, an anticholinergic medication that can quickly resolve a syndrome like this. Atropine is another one that can cause, if we gave them too much stuff to reverse the anticholinergic and we went too far the other way, that we're seeing a lot of cholinergic syndrome, atropine can cure the cure if things are taken too far on the other path. So just to go over real quick, a recap of the different syndromes that we talked about today. So serotonin syndrome, the main things are the clonus and the hyperreflexia. In NMS, there's usually not clonus or hyperreflexia. So that's something that you can look out as a differentiator between the two syndromes. Anticholinergic toxicity, usually you're going to have dry skin and absent bowel sounds because of the anticholinergic symptoms. You'll remember in serotonin syndrome, we talked about that there's increased GI sounds like diarrhea and vomiting. So that's another way we can kind of tell these apart. A really cool or interesting way you can tell these apart is by their eyes. So they all have different kind of eye syndromes. So in serotonin syndrome, there's that ocular clonus, which is, kind of like not having any stimuli, but the eyes are shaking. And there's good videos of this on YouTube if anyone's curious to look. NMS will all have like a fixed staring where the patient will kind of be just kind of in a fixed gaze looking at the interviewer without any shaking. And anticholinergic toxicity, rapid saccade. So if you're doing kind of testing the ocular motor muscles, them coming back horizontally, there'll be kind of like a shaking as they're trying to correct, as they're going along from side to side, there'll be some shaking, and you can also look up a video of that on YouTube as well. So, treatment, benzos are the mainstay treatment for most of these. Whatever is causing the syndrome, you have to take that away. So if it's serotonin syndrome, you take away the serotonergic agent. If it's NMS and there's an antipsychotic, you take away the antipsychotic. If there's anticholinergic excess, they're taking a bunch of hydroxyzine and Benadryl, you're discontinuing those medications. And then supportive care, maintaining stability of their vital signs is important for all of these, because all of these have some autonomic distress, and that's what can lead up to the severe complications. So I think that's pretty much wrapping it up. Here are my references, and these are also on the slides as well. And then this is a QR code. I don't know if Alex, if I should leave this slide up for a little bit, but if there's any questions, I'd be happy to answer what I can. Thanks again for letting me present. I really appreciate the opportunity.
Thank you, Dr. Abeyta. If anybody has any questions, please feel free to chime in now. Also, Dr. Abeyta, thank you for presenting today. It was very interesting, and yeah, I really enjoyed it.
Thanks. Yeah, appreciate it.
I will share the CE link in the chat now for those interested in filling out the survey to receive a certificate. If you have any questions about that, please feel free to reach out to me directly. We'll just give it another moment here to see if anybody else has any questions.
Maybe I can ask a question, Dr. Abeyta, for the group, who I think, the audience is largely community providers, therapists, social workers. So if you have any advice for that population and how to sort of deal with it if a patient were to come in for therapy or some other service, kind of how to handle that if you don't have a lot of this background in the medical knowledge.
Yeah, so thanks, Megan. So like I said, a lot of these syndromes have a spectrum. So they can present, just kind of feeling different than usual, like kind of shaky, feeling kind of off, and if it's resulting after a medication change and they let you know, like, hey, I saw my psychiatrist yesterday and he upped my dose of my antidepressant, and today I'm just kind of feeling shaky and uncomfortable. Someone in the community can see that, maybe it's because their body's getting used to a med change, or maybe it's something that, they should go to an urgent care at least and get like a quick, medical workup. Because it's something that can show up as a spectrum. It's something that can present in community locations, because maybe the patient is not feeling a full severe serotonin syndrome or NMS, but they're presenting with kind of beginning symptoms, and if caught early, it's something that could be very helpful in preventing severe outcomes. So I would just be cognizant of symptoms, and again, medication history. If any of these symptoms are coming after a result of a recent medication change, then that'd raise my suspicion of maybe you should go to an urgent care or an ED just to make sure that everything's okay. So that would be my advice.
Also, what about, I know that a lot of people take supplements that aren't regulated and they can interact with psychiatric medications. So just that kind of came to mind too. Like if someone is maybe on their medications and there hasn't been a change, but they tried a new supplement, that's something to kind of think about, increase your index of suspicion.
Totally, yeah. There's like I said, there's a lot of like uncommon stuff that we wouldn't think about. I think the most famous one, or most known one, is St. John's wort can cause serotonin syndrome. So yeah, also, if someone comes in with symptoms and they're like, yeah, I just started this X medication or this supplement, any medication change, because there's so many medications that can cause or contribute, would raise my suspicion that something else may be going on.
And then what about, does this present differently, or are there any considerations for older folk who might, be getting care in the community?
So I think their symptoms are mostly the same, although, if you look at the data, most of the cases that ended up in mortality were elderly patients. So, it's just another thing that we really have to be cognizant of these symptoms, because, the elderly patients are the ones that are most likely having the severe cases. So something to keep an eye on. So I would just say there's not a lot of difference in the way they're presenting, but the severity can be worse.
Anybody else have any questions or comments for Dr. Abeyta? All right, well, thank you, Dr. Abeyta, for taking the time, and thanks everybody else for joining us today. And if you have any questions, please feel free to reach out to me or Dr. Shed or Dr. Abeyta directly. Otherwise, we'll see you all next time.
Thank you.
Thanks so much,
Thanks, everyone.
everybody.
Bye.
See ya.